The plethora of treatment options gave rise to the need for comparative effectiveness research. Increasingly more systematic reviews focus on comparing the efficacy and acceptability of many, if not all, available interventions for the same condition. Even within a class of interventions, there are many options, and they are not necessarily all equal. For example, Cipriani and colleagues found that mood stabilizers and antipsychotic drugs differ in their efficacy and acceptability when treating bipolar patients. Randomized controlled trials that compare all treatment options are usually not feasible, so other methodological approaches are needed. Cipriani and colleagues collected 68 randomized controlled trials involving over 16,000 bipolar patients to compare various pharmacological interventions used for treating acute mania. This collection of trials forms a network of evidence where nodes represent interventions and edges represent at least one direct comparison between interventions. Network meta-analysis is a natural extension of classical pairwise meta-analysis and can be used to compare all treatments that are connected to each other in a network. The technique has earned a crucial role in comparative effectiveness research, particularly in national organizations developing guidance for healthcare, such as the Institute for Quality and Efficiency in Healthcare in Germany, or the National Institute for Health and Care Excellence in the UK. The method is based on the simultaneous synthesis of direct evidence, which comes from studies directly randomizing treatments of interest, and indirect evidence, which comes from studies comparing treatments of interest with a common comparator. The concept of indirect comparison is central to network meta-analysis. If two treatments, haloperidol and quetiapine, have both been compared with a common treatment, say placebo, in two different sets of trials, placebo versus haloperidol and placebo versus quetiapine, then the relative efficacy between haloperidol and quetiapine can be estimated indirectly via placebo. We basically perform a meta-analysis for each direct comparison versus placebo, and then we subtract the two estimates to get the indirect treatment effect. In a larger network of treatments, there is not necessarily only one indirect path from one intervention to another. In a full network, indirect evidence about haloperidol versus quetiapine can be obtained via multiple routes by combining the direct estimate that each path involves. Additionally, when direct evidence about haloperidol and quetiapine is available, it is possible to synthesize it with indirect evidence into a single powerful pooled estimate, which is termed network treatment effect. A network meta-analysis formalizes this process in a statistical model and combines data from all studies simultaneously. It provides relative treatment effects for all pairs of interventions, even for those without direct evidence. It can improve power by reducing the width of the confidence intervals compared to those obtained from direct evidence alone. When relative treatment effects are estimated, randomization is preserved. However, indirect comparison and network meta-analysis provide observational evidence because treatments being compared have not been randomized across individual trials. Before interpreting results, it is important to understand the structure of the evidence base and its characteristics. A graphical presentation of the evidence network provides an accessible and understandable format for describing the evidence. By plotting nodes and edges proportional to the amount of information they carry, the graphical presentation conveys how much evidence is available for each comparison and which contributes most. Colors in the edges can be used to convey additional information, such as the risk of bias in the included studies. One of the challenges is how to present the complex set of outputs. It is useful to report estimates for all pairwise treatment comparisons with their corresponding uncertainty intervals, possibly for more than one outcome. Alongside the network meta-analysis estimates, the direct estimates can be presented to provide a complete and transparent picture of the available results. Most published articles use a league table or forest plot-alike graph to report this information. A key strength of a network meta-analysis is that it can lead to a single coherent ranking of treatments. Probabilities for each treatment taking each possible rank can be presented in a table or in a rankogram. It is important to look at such graphs rather than the naive ranking or the probability for each treatment to be the best, because drawing conclusions based on the latter might be misleading. Ranking measures and probabilities are straightforward to understand and a convenient way to present network results, because clinicians usually want to know the preferential order of treatments that could be prescribed to an average patient. However, ranking measures should always be interpreted together with the effect sizes, because a good rank does not necessarily imply a large or clinically important treatment effect. When setting up a research question for a comparative effectiveness review with network meta-analysis, investigators should make sure that the treatments they plan to compare are jointly randomizable. That is, one can imagine a multi-arm randomized trial involving all treatments intended to be compared. This should be explicitly stated in the protocol of the systematic review. This notion of jointly randomizable treatments is linked to the main assumption of transitivity underpinning the validity of indirect comparison. The assumption of transitivity implies that the different treatment comparisons put together in the network do not differ with respect to the distribution of variables that can modify the relative treatment effects. For example, a valid indirect comparison of haloperidol with quetiapine can be obtained if the two sets of studies, haloperidol versus placebo and quetiapine versus placebo, are similar in severity of illness at baseline, treatment dose or study quality. So transitivity can be viewed as the extension of clinical and methodological homogeneity across groups of studies that compare different treatments. The plausibility of the transitivity assumption requires judgments to be drawn about the comparability of the distributions of the effect modifiers across studies. However, effect modifiers are often unreported in studies, or there are too few studies available per comparison to enable reasonable judgment. So in practice, transitivity is often an untestable assumption. Consistency is the statistical manifestation of transitivity in the dataset and occurs when direct and various sources of indirect evidence are in agreement. Consequently, consistency can be evaluated only in closed loops of evidence. The distinction between transitivity and consistency is analogous to the distinction between clinical or methodological homogeneity and statistical homogeneity in standard meta-analysis. There are several statistical methods to evaluate whether a network is consistent and detect hotspots of inconsistency. All methods, however, are characterized by low power, and their performance depends on the amount of residual within comparison heterogeneity. Empirical evidence has shown that inconsistency can occur frequently in networks of interventions. Examination of published networks with dichotomous outcomes published until February 2011 revealed that 1 in 8 networks was inconsistent. Once a network is found to be inconsistent, several approaches are possible. Investigators can perform subgroup analysis or network meta-regression using predefined characteristics. A special model can be employed to account for small amounts of residual inconsistency by adding extra random effects to the different sources of evidence. However, application of such inconsistency models requires statistical expertise. To date, the vast majority of network meta-analysis include only randomized trials. Some early attempts to include real-world evidence from observational studies appear now in the literature. In such networks, justification of the transitivity assumption becomes very challenging. However, well-conducted, consistent networks that include observational studies can arguably provide information which is more relevant to real-life situations. It is also possible to combine the results from network meta-analysis with other population-based information to make predictions about the large-scale impact of medical interventions in people's health. Systematic reviews that employ network meta-analysis become popular as initial doubt about the methodology fades away and user-friendly software becomes available. Network meta-analysis successfully tackles the complexity of contemporary decision-making, and it is expected to become the new norm in evidence synthesis.